Hello, friends. So I'll be talking on this topic, which I was asked to give a talk on in KPCon, Karnataka State Chapter Physicians Conference on 20th August 2022. So I'm sure most of you would wonder why we are talking on this again, because COVID is almost gone. At least they're not coming with severe sort of a condition needing ICU admission. Nevertheless, we were given this topic, so I just deliberated to give an overview on what are the therapies that are still relevant for severe COVID at this point of time. So what I've done is I've predominantly would be talking on only the latest studies and precisely studies which have come in 2021 and not before that, because there are that many studies that have come during COVID. It is impossible to talk about all those trials. So we'll see how we can just have a good overview on this topic. So when you look at any COVID, so the therapeutic armamentarium is curated to the stage of the disease, because you have this early stage of the disease where they are asymptomatic or mild. That is when the whole viral replication happens, and there are certain drugs positioned, antiviral therapies positioned at this stage to prevent progression of the disease. And after this early phase, then they go into this intermediate phase where there is an extensive sort of an inflammatory response from the body which develops. And there are medications which are positioned for this sort of a stage of the disease, like steroids, tocilizumab, and so on and so forth. And then you have this antibody cocktail also, which is present, and the critical illness where they come to ICU, then you have other armamentarium like mechanical ventilation, ECMO, so on and so forth. So basically, the therapeutic armamentarium is customized to the stage of the disease. So that is what we need to bear in mind. So I would divide the sort of therapeutic armamentarium into the four pillars in COVID. So the first pillar I would say is the antivirals. So as you would be aware, friends, so we had initial enthusiasm that came with hydroxychloroquine, ivermectin, ritonavir, favipiravir, remdesivir, and molnupiravir. So right now, all these drugs are questionable. They do not have any effectiveness against the COVID. So the drugs that are here to stay possibly at this point of time with whatever evidence we have is remdesivir and molnupiravir. When you talk about anti-inflammatory, then steroids are here to stay. So there is a debate on whether high dose steroids would be beneficial or more effective than low dose. The current understanding is low dose steroids, that is 8 mg dexamethasone, is good enough at this point of time. And there is no major difference between using high dose. In fact, some of the studies have shown higher mortality. And the STOIC trial, which spoke about budesonide inhaler in the early part of the disease. So that also seems to have some promise. Then we have this tocilizumab, itolizumab, and bevacizumab, but only tocilizumab has stood the test of time and it seems to have some role. And then came this JAK inhibitors, baricitinib and rocatinib. So this is about the anti-inflammatory sort of the drugs that would be used in the phase when they develop inflammation. Colchicine has been touted from now and then, but as of now, there is no robust evidence to suggest that it has any bearing. Then the third pillar of management of COVID is because in inflammatory phase and after that, there is extensive sort of a procoagulant state, and the use of anticoagulation is purported. So the whole debate is whether it has to be prophylactic low molecular weight heparin or therapeutic low molecular weight heparin. And aspirin, thrombolysis, and some of these newer drugs like Usadigat and Abradil. So right now, prophylactic low molecular weight heparin is here to stay, and it has had good evidence, but there is no role at this point of time for therapeutic anticoagulation in COVID unless they have proven sort of a they have a procoagulant state with a venous thromboembolism or arterial thromboembolism and so on and so forth. Then the fourth armamentarium is the use of antibody cocktails. So there are a lot of drugs that have come, like casarimimab and imdimimab is currently available, and then this pegylated interferon lambda came. There was a good sort of a Canadian trial which showed little effectiveness. But what is here to stay is possibly cocktail. We don't know whether it is definitely wouldn't be very effective against Omicron, but for our Delta and other variants, this cocktail seems to have a promise. And convalescent plasma, there was a lot of initial enthusiasm, but right now it is obsolete. So in fact, there are guidelines or suggestion or recommendation against the use of convalescent plasma in COVID. So this is the sort of a picture one would have to bear in mind when you're talking about COVID. So you have four pillars, and these are some of the drugs which possibly remain relevant for severe COVID even now at this point of time. And now after this in ICU, these are time-tested modalities. Oxygen, yes, if they're hypoxemic, they would need oxygen. And awake prone positioning does seem to have a role to play in favoring or enhancing the recovery process and preventing further progression. And all these modalities we have used during COVID in severe cases when oxygen requirements go up, the role of HFNO and NIV, and proning with HFNO and NIV also has to be encouraged in severe COVID. This is to prevent further progression and facilitate early sort of a recovery process from the severe COVID. This has been, so this is something which we have adopted as a norm in COVID, use of HFNO and these devices, NIV, and proning the patient goes a long way. And intubated and mechanical ventilated, proning them early on so that we enhance the recovery. And there is debate on whether we should intubate early or late, and different types like L type and H type, where L type has low elastance, high compliance, H type has a high elastance and low compliance. But all this is now debunked. So we would intubate at a point of time that patient requires intubation like any other respiratory case. So there is no debate or debate as to whether we should delay the intubation for these patients. And as a salvage measure, ECMOS has to be done as a desperate measure. And there are certain anecdotal reports of use of hyperbaric oxygen therapy in COVID. In fact, we published an article on hyperbaric oxygen therapy in COVID and the role of pirfenidone, nintedanib, and lung transplant as a desperate measure. So this is the review article that we published on the possible role of hyperbaric oxygen therapy in COVID. So now we look into the evidence. As I said, I've only taken studies which have come in 2021 only and which are relevant, and the therapies which are relevant at this point of time. So this is the most latest study. So if you recall, friends, even remdesivir was sort of criticized as being ineffective based on the solidarity trial that came from WHO. After the solidarity trial came, this particular trial was published in NEJM, where the study was done to see if early remdesivir usage in OPD setting would prevent progression to severe COVID. So here they took patients with symptom onset less than 7 days with one of the risk factors, which would portend disease progression like age more than 60 years, obesity, comorbidities. Here the dose they gave was 200 mg once a day, followed by 100 mg once a day for 3 days. So the primary endpoint they looked at was medically attended visits to the hospital and 28-day death. 61.6% were diabetics, 55.2% were obese. Which means these were they had to have these risk factors, which sort of determines their risk for disease progression. And 47.7% were hypertensive. So when they looked at results, mean age was 50 years, 47.9% were females. They had 562 patients. And if you look at the 28-day death, 279 in the remdesivir group, 283 in the placebo group. 28-day death was significantly less in remdesivir group as compared to the placebo. That was significant. And medically attended visits, which means patients needing to go to hospital for any sort of a treatment or for any discomfort or symptoms that needed attention, was significantly less in remdesivir, which means you give remdesivir within 3 days, for 3 days in the early onset of the disease. It prevents death and it prevents patients going to hospital for seeking any relief as compared to the placebo group. That was also significant, and adverse events were similar in both groups. So the conclusions authors made was remdesivir given for 3 days in the early part of the disease on a OPD basis, there was 87% lower risk of patient needing hospitalization or deaths. So this again sort of rekindled our enthusiasm on still possibly remdesivir having some role in preventing progression of the disease in high risk patients, patients who are more than 60 years, who are obese, who have other comorbidities. It may still have some role to play, is what this study told us. Then there was excitement about molnupiravir. So molnupiravir, just a very brief about molnupiravir drug. So this is a potent ribonucleide analog, which is shown to inhibit the replication of the virus. And the molnupiravir contains this active ingredient called N-hydroxycytidine. And when molnupiravir is ingested, it gets cleaved into this active product called EIDD 931. And in the presence of kinase, it gets converted to the N-hydroxycytidine. So this RNA-dependent RNA polymerase, which is present in the coronavirus, which leads to the replication, it uses cytidine triphosphate and uridine triphosphate. So it, but with the when molnupiravir is used, so instead of using CTP and UTP, it uses N-hydroxycytidine and then gets converted to guanine adenosine, which creates viral error catastrophe. Basically, it creates abnormalities in the genetic components of the virus, and that leads to that sort of becomes effective in preventing the replication of the virus because there are errors created. So now this drug was criticized because there is genetic errors that are created within the RNA. The hypothesis was whether it leads to any other side effects. So because it sort of puts in viral error catastrophe or the defects in the genetic sort of a makeup, which prevents the replication of the virus. And that's the mechanism of action. So there were good trials, phase 2 and phase 3 trials. So this was a phase 2 trial called a move out trial, where they showed use of molnupiravir 800 mg when compared to the placebo. The day 3 viral count was significantly came down to 1.9% as compared to the placebo. And at day 5, no virus. So basically, molnupiravir was found to be effective in eliminating the virus or significantly reducing the viral load in the patient. And they tested in this phase 2 different doses. As you see, it is a dose-dependent effect, and they found that optimal dosage at which the virus level significantly comes down was at 800 mg. Because at 400 mg, the viral came down to 11.6, and 200 mg it was 18.2%. So which means to say at 800 mg, it had a good role in reducing the viral burden or the viral load. And after this particular trial came, which is a phase 3 randomized controlled trial, again called the MODE study group, came in 16 December 2021. They took 1,433 patients, 709 in the molnupiravir, 699 in the placebo. And if you look at the hospitalization and death, it was 6.8% in the molnupiravir and 9.72 in the placebo group. It was significant, and the deaths was also less in molnupiravir group. And the conclusions one could make is molnupiravir, when administered within 5 days of the symptom onset, it was shown to be effective in reducing the risk of hospitalization and the risk of death at day 29. So again goes on, and this molnupiravir was found to be effective against Delta, Micro, and this Gamma virus. But we don't know because when this study was done, they are not included Omicron. So now the criticism is whether molnupiravir would be effective against Omicron is a question that we do not have a definitive answer for. But molnupiravir does seem to have a place even now in COVID, especially if it is other strains of viruses, if you have to subscribe to the evidence currently available. So this is about the molnupiravir study. So that's about the antiviral. So right now, remdesivir and molnupiravir, at least with regards to evidence, they seem to have some evidence supporting their usage at this point of time. And then now we look into the inflammatory phase. So the whole paradigm of COVID changed with this recovery trial. So this is the only study I'll be talking 2020 because after that there was no major steroid trial. So this recovery trial was the game changer because this was a big study done in 11,500 patients across 175 hospitals, and this was a six-armed study. As you see, the study was six-armed where they looked at the effectiveness of lopinavir, dexa, hydroxychloroquine, azithromycin, tocilizumab, plasma. Here we'll talk only about the role of steroids in COVID. So 6,425 patients were enrolled where steroids were used, and they looked at the 28-day mortality. And as you see in the 41% of them were mechanically ventilated, 25% needed oxygen. So the group, 2,104 patients out of 6,425 got dexamethasone, 6 mg per day for 10 days. The 4,321 patients got usual care, and they found in the group that got dexa, there was 17% reduction, or one third of the patients did not need mechanical ventilation in the group that they got steroids. And even the oxygen requirement also significantly came down by 1/5, which means the need for oxygen also significantly came down as compared to the placebo. So this again re-emphasized that steroid was a game changer. It significantly reduced the need for mechanical ventilation in one third and significantly reduced the need for oxygen or reduce the oxygen need by in 1/5 of the patients, which as compared to the placebo, which was very significant. And number needed to treat to achieve this was 8 for mechanical ventilation, and for oxygen it was 25. So this really changed the whole therapeutic practices in COVID, and steroid usage was widely adopted. Then possibly the listeners would ask whether there is any difference with the dosage of steroids. So there are multiple studies. In fact, 2022 there was a meta-analysis that came, which really shows there is no difference between high dose steroid and low dose steroids, which is 6 mg dexamethasone. 6 mg elemental dexa. In India, we use 8 mg because 8 mg contains elemental active dexamethasone component of 6 mg. So 8 mg dexa, what we are using here, is at this point of time good enough. We don't need to use pulse therapy methylpred, or see the 8 mg dexamethasone what we use here is equal to 32 mg of methylprednisolone. So using very high dose methylprednisolone like 60 mg, 120 mg also at this point of time is not justified for COVID. So this is something which you could keep in mind. Then we'll move to the tocilizumab. So again, the tocilizumab, there are more than 10 trials, good quality trials that came, but we wouldn't talk about all those. So we'll talk only about this latest trial which came, which called the remap cap sort of a study. So this study was done by UK group, and it was published in NEJM in February 2021. So here, what they looked at is they looked at odds ratio more than one was taken as patients with improved survival, and odds ratio of more than one suggested that more organ support free days is what patients had, which is a good thing, or both. So when you look at this findings, so 353 patients were in tocilizumab group, 48 were in sarilumab because this was a 3-arm study, and 402 was standard therapy. When you look at median organ support free days, which means it has to be longer, so they found there was a significant benefit with the use of these interleukin inhibitors. And if you look at the median adjusted cumulative odds ratio, as I said, odds ratio more than one would suggest that patients have improved survival and would have more organ support free days. So here odds ratio was 1.64 in tocilizumab, 1.76, which means these had effect on improving the survival, and they had effect on increasing the organ support free days, which is a good thing. So which goes on to show that tocilizumab or these interleukin 6 inhibitors had a beneficial role. And 90-day survival also was better. As you see, it was statistically significant as compared to the standard group. And hospital mortality also, it signals towards being less at 27% as compared to 36% in the control group. So the conclusions authors made was in COVID-19 patients where you have an escalating need of organ support in the form of NIV or HFNO, when used within 24 hours. So the treatment with IL-6 receptor antagonist improves outcome and survival. So which means if you use it within patients needing organ support for respiratory or serious, it means if they are having a cascading need of oxygen in the form of NIV, HFNO, or cardiovascular sort of a uh, decompensation is setting in, needing vasopressor. So use of this showed improved outcome and survival. So remap cap is the sort of the most recent study, which again tells us that there is still a role for usage of these drugs in severe COVID at this point of time, the IL-6 receptor antagonists. So then came this JAK inhibitors in COVID. There are two JAK inhibitors, baricitinib and tofacitinib. So this is also a new kid on the block. So baricitinib inhibits Janus kinase 1 inhibitors and Janus kinase 2 inhibitors. So what does it do by inhibiting Janus kinase 1 and Janus kinase 2? So by inhibiting these, it inhibits certain intracellular signaling sort of a pathways that exist, and it reduces the production of these cytokine storm, which is like a production of IL-2, IL-6, interferon gamma, and GCSF. So it interferes with the intracellular signaling pathways and reduces the burden of these cytokine storm and the interleukins. And it is also shown to impair AP2PK protein kinase, and this prevents entry of virus into the cell. So this is the two ways in which JAK inhibitors were effective. And it also increases the lymphocyte count, because we know in COVID, severe COVID, lymphopenia is an important marker of severity of the disease. So this is the way the JAK inhibitors act. So there was this study which was published in 2020 where they compared remdesivir versus remdesivir with baricitinib, where they used 4 mg of baricitinib, say 2 mg twice a day for 14 days. And they used 2 mg once a day in patients with GFR less than 60 ml. So the conclusions they made was the use of remdesivir alongside with baricitinib was superior to using only remdesivir in reducing the time to recovery and accelerates clinical improvement more so in patients who are on HFNO and NIV, and it reduces the serious adverse effects. So you can look into my previous video where I've spoken in detail about the findings of this study. So I just put in a small sort of a tabular format as to the study, but you can go through the video where I have specifically spoken only about the JAK2 inhibitors. And then after baricitinib, then tofacitinib is another JAK inhibitor. So there was a study that came where they used tofacitinib plus dexamethasone versus only patients who got dexa. They used tofacitinib 10 mg twice a day for 5 days. There were 269 patients, 138 in the tofacitinib plus dexa and 131 in the dexa. As you see, mortality was significantly less when tofacitinib was added to the dexa as compared to only dexa, and there was 70% reduction in the odds ratio of them dying, and that was statistically significant. So which goes on to say that along with steroids, which is a game changer, adding this JAK inhibitor tofacitinib had a much more enhanced beneficial value is what we could see. And these drugs are here to stay. They're not very expensive. And we have been using it routinely now for severe COVID in our patient group. And one would have a concern of the increased risk of infection. In fact, this particular study showed there was no difference with regards to risk of infection. And the bleeding sort of tended to occur little more commonly in this tofacitinib and dexa group. And hyperglycemia was more common in the dexamethasone group. So that is about the anti-inflammatory. So steroids are here to stay. So low dose steroids is good enough. There's no role for high dose steroids. When it comes to interleukin 6 receptor, tocilizumab, because of remap cap study, it does seem to have a role to play in severe COVID. And JAK2 inhibitors are here to stay. They also possibly have some benefit. So what about anticoagulation? So there are two good trials that came. So this was a trial that came in June 2021 by Brazilian authors called the Action Trial, where they used therapeutic anticoagulation and compared to prophylactic anticoagulation in severe COVID. And they found there was no difference. In fact, the risk of bleeding significantly increased where therapeutic anticoagulation was used. This came in Lancet. So this was another study called the Inspiration Trial, where they used little higher anticoagulation at 1 mg per kg once a day and compared to standard 40 mg of enoxaparin. Even here, they did not find any difference between therapeutic or prophylactic anticoagulation. And in fact, the therapeutic anticoagulation sort of a group had a more thrombocytopenia in this particular study. And then there are these three randomized controlled trials that came comparing prophylactic and therapeutic anticoagulation. And all these studies showed there was no difference with regards to survival between therapeutic and prophylactic. And major thrombotic events was found to be little less in therapeutic anticoagulation. And major bleed was found to be little more, but none of them were statistically significant. So the conclusions we can derive is therapeutic anticoagulation could only be considered where there is suspected venous thromboembolism or suspected arterial sort of a thrombosis in the setting of any lines that are present, or there is sudden acute deterioration in respiratory status with increased fibrinogen or profound increase in D-dimer. These are special situations where one could consider therapeutic anticoagulation as a salvage measure. In fact, we went a step ahead to look into the possible role of thrombolysis because we did our own study because there were trials that were happening in this, and we have published this study. This is due for publication in International Journal of Critical Care. Thrombolysis as a desperate measure or a salvage measure in patients who had acute worsening with more than 10-fold rise in D-dimer, we did find benefit in survival by using thrombolysis. Anyway, we won't talk about it. Then the last bit of the talk would be an antibody cocktail because there was a whole lot of enthusiasm towards the later part of the second phase of the disease of usage of this antibody cocktail. And this study came in again NEJM in 2021. So basically this casirivimab and imdivimab, they act on the spike protein and they block the spike protein and prevents the entry of virus into the cell. So they bind to the receptor binding domain of the spike protein and prevent the entry of this because the virus gains entry into the cells through the spike protein by blocking this with this antibody, so the virus cannot gain entry. So it was found to be effective against mutant strains, and this is the structure of the whole receptor binding protein on the spike protein. So what they found is they did a study comparing placebo versus 2.4 grams of this cocktail, casirivimab and imdevimab, which is called Regeneron COVID, and they compared with 8 grams. 93 patients in placebo, 92 in 2.4 grams, 92 in 8 grams. So they had 277 patients. So they looked at the change in the viral sort of a load, and they found significant reduction in the viral load in the patient group which got antibody cocktail. And percentage of patients needing hospitalization also was less in patients getting antibody cocktail. And in patients where antibodies were negative at the at the baseline, antibody cocktail was found to be more effective, which means to say if patient is having inability to maintain and to mount an antibody response, they are at a higher risk of progression to severe disease. And this antibody cocktail seemed to be more effective in that group rather than in the patients who would mount a good antibody response. So that was an important point that was highlighted in the study. And hypersensitivity was similar between the two groups. And again, here they compared two dosages and they found the change in the viral copies was similar. Either you use 2.4 grams or 8 grams. That's why if you see today, friends, when you're using antibody cocktail, we split that for two patients because even 2.4 grams was as effective as higher dose. That's why the packaging happens with full dose. So we divide the dose because half dose is good enough in having good antibody levels and circumventing the progression of the disease. So the conclusions from this trial was the Regeneron COVID-2 or the antibody cocktail does reduce the viral count, especially in patients who are unable to mount immune response, who are unable to increase their antibodies. And it is more effective in patients who have a higher viral load as compared to the lower viral load, and safety outcomes are similar. So again, this is here to stay. Again, one could argue, all the listeners could argue, this particular cocktail may not be effective against Omicron because Omicron is associated with the S protein mutation and it is known to cause antibody evasion. Because it evades the antibody and there is a S protein sort of a mutation. So this molecule may not be effective against Omicron. So the take home message at the end of this exhaustive talk. So what are the molecules that are here to stay as per the current evidence? The antivirals, remdesivir, molnupiravir, if you have to subscribe to the evidence, it seems to have a role at this point of time. Nirmatrelvir is not available in India. And the advantage of Nirmatrelvir is it can be used in pregnant ladies. This is available as a combination. So Nirmatrelvir with ritonavir. And anti-inflammatory steroids are here to stay. And low dose is good enough. Tocilizumab is here to stay. And JAK inhibitors are here to stay. And anticoagulations are here to stay. And it is a prophylactic anticoagulation. And there is no role for therapeutic anticoagulation at this point of time. Antibody cocktails are here to stay for Delta variants and other variants, but Omicron, it is not effective. But the newer antibody cocktail called bamlanivimab and etesivimab is found to be effective even against Omicron is what we are told. So we need to look at the study part of this molecule and it's not available in India at this point of time. So that's about the current understanding of COVID, friends. So thank you one and all. So with this beautiful quote, so everything you ever wanted is on the other side of here. Thank you one and all.